Start now. Good afternoon, doctors, pharmacists, ladies and gentlemen. Thanks for spending your time joining us in this evening webinar organized by Eurodrug Malaysia. My name is Susan Yap, the Sales and Marketing Manager of Eurodrug Malaysia. We are a Netherlands-based boutique pharmaceutical company, and recently we launched a new product, Furoxan, with the active ingredient Doxofylline 400 mg. So this is a new oral therapy available in Malaysia, and it is indicated for asthma and COPD treatment. And this webinar today will take about 45 minutes and followed by a Q&A session. So if you have any question along the presentation, you may type in the chat box or to save your question after the presentation for further discussion. And we are very happy and appreciate today as we managed to invite our colleague from the Netherlands, Matthijs, who is the Medical and Development Manager of Eurodrug in the Netherlands, to share with us on the role of Doxofylline in managing asthma and COPD. So without further ado, let's welcome Matthijs. And Matthijs, over to you, and good morning.
Well, good afternoon, everybody. Indeed, thank you, Susan, for the kind introduction. Here in the Netherlands, it's still very early, 10 o'clock in the morning. I'm happy to present today a little bit about Doxofylline, but two main disclaimers before I start. The first disclaimer I have is that I am not a medically trained person. I have studied biopharmaceutical sciences, and therefore it might be I have never encountered patients. So I would like to disclaim this to know that I'm giving you a brief introduction into the scientific background of Doxofylline, but I do not actually have experience with treatment of Doxofylline myself. Second disclaimer is that I am the Medical Development Manager of Eurodrug, and therefore I'm today going to present about Doxofylline, and I will just try to present it in a most neutral way as possible. However, sometimes I'm a big fan of this therapy, as you can imagine, so therefore I'll always be keen on introducing the scientific rationale in a way that I think is the best, but it can be that you might disagree with me. I'm always interested in the discussion, so please raise your questions and I'll answer them at the end of the presentation. Today, we'll be talking about the roles of Doxofylline in asthma and COPD, and therefore I will give a general introduction into the therapy and what kind of clinical evidence there's present. And to start off, we'll start with what kind of drugs are there for asthma and COPD. I think most of those drugs are well known to you. We have corticosteroids, both inhaled and in the tablet form. We have beta agonists, and we have LABA, SABA treatments, LAMA, SAMA treatments as well, short-acting, long-acting. But among these, we also have for oral therapies, we have xanthines. And the category of xanthine therapy is what I'm going to talk about today. Xanthines are derivatives from, if you take a look at the whole field of the current treatment options we have nowadays, both short-acting and long-acting, they are all considered valid treatments for asthma and COPD, based on the clinical symptoms the patient has. Based on the severity of the treatment, you have short-acting and long-acting, and also fixed combinations are available. What's really important is that I base my view on the European market. It might be that not all combinations are available in Malaysia as well. However, these are treatment options in general. And on the bottom, in the long-acting category, you see that we have xanthines, theophylline and doxofylline. Those are two well-known xanthine therapies for COPD and asthma. So if we take a look at the molecule structure, you see that they all have a caffeine-based ring with a couple of nitrogen atoms in it, and doxofylline is among this group of xanthines, and you see that in aminophyllin and bamifillin, the center structure comes back again. Aminophyllin and bamifillin are lesser well-known treatment options, and I believe that bamifillin is not even available on the Malaysian market right now. And recently, we had the pleasure to launch doxofylline, and we call this therapy a novel filling because, and I will explain during my presentation why we think it's a novel filling and therefore should be considered a little bit different than the above mentioned therapies. Structurally wise, the main difference is that it has a dioxolane group in the 7th position, and that makes it significantly different from, for instance, theophylline as well. Well, to dive a little bit deeper in the mechanism of action and the pharmacokinetics and pharmacodynamics of this therapy, we currently do not have an exact knowledge of how the xanthines work. There hasn't been a very deep and thorough understanding on the molecular level about the mechanism of action. What is considered is that it has impact on the PDE pathway and also the adenosine cyclase pathway as well. And these two findings have that will relieve the patient of their distressing symptoms of their bronchoconstriction and other bronchopulmonary symptoms. In vitro, it has been found out it has three main effects, and of those three effects we'll dive in a little bit deeper, which is a bronchodilator effect, an anti-bronchospasmodic effect, and an anti-inflammatory effect. And I will dive in that in the upcoming few slides. The maximum peak time is approximately of concentration is approximately after 1.5 to 2 hours, so it's quite rapidly absorbed. And the half-life is approximately 7 hours. So it means that it's a double dose treatment, so 2 doses a day, or can even be given 3 times a day if not sufficient for the patient as a relief. So doxofylline offers quite a broad therapeutic window to operate in with the patient. So the immediate release version we have on the market in Malaysia is 400 milligrams and can be given 2 or 3 times a day, depending on the severity of the symptoms. So what kind of preclinical findings have we found? So when this therapy was discovered, it's been already a while ago, as you can see from the reference on the bottom, around 1985, this molecule was developed, and what they found in in vitro lung model with guinea pig lungs, that when they had platelet activated factor added to those lungs, which will just give a bronchoconstriction-like symptom, they saw that doxofylline dependently reduced the bronchospasmodic effect. And what you see over here is a little bit less effect compared to theophylline, but this is only in vitro, so the different molecules work in different ways, and therefore we think it's a very clinical relevant finding that we had doxofylline here showing this anti-bronchospasmodic effect, reducing the airway resistance over time. What we also saw is an anti-inflammatory effect. And this was again confirmed by Risto Vasquez et al. In 2014, where they took various lung tissues and they added LPS lipopolysaccharides on it to induce inflammation. And after a while, they saw that also dose-dependently, the TNF-alpha and the interleukin-6 present inside of the cells reduced over time. What does it mean? It means that doxofylline inhibits inflammation and therefore gives more way, reduces the airway resistance, and therefore gives more air and more bronchodilation to the patient. To continue from here, of course, the preclinical findings are interesting. There are many more clinical findings, but I found those two to be most interesting because they depict how the therapy works. but to my experience and to my understanding, I think that the clinical findings are much more relevant. There has been many studies performed with Doxofylline, but let's go first into the China guidelines. So Doxofylline isn't being mentioned in China, nor is it in the gold guidelines. However, theophylline of the same group is mentioned as other controller options, but not as a first go-to. And will explain briefly why this is. Doxofylline is first of all, not available in the US and the UK, but has been broadly used inside of Europe. And therefore, because it's not so broadly available, the main reason for this is because it's been developed earlier, and then there was the surge of the inhaler therapies coming along, which is proven to be so clinically effective at that time, and that there was no interest for placing to further perform this humongous clinical trials nowadays required for China and gold guidelines, and therefore you see that these treatments are not considered in the guidelines yet. However, theophylline is mentioned because it's already a very old molecule, 70 years old, and we have a lot of data showing comparison effect with Doxofylline, which I will go through with you right now. So notice, although it's not in the guidelines, it doesn't mean that it isn't a very valid option. It's just that it's not considered by the reviewer committee so far. However, for Doxofylline, we have had many years of experience as a company, and we have had great success with the therapy. So I can really recommend you, Eurodrug promoting his own products, of course, of considering this therapy. So let me go through with you the clinical evidence. So one of the biggest studies performed were the Dorotheo studies. The Dorotheo studies have been performed in the 90s, but only until 2018 there was a review of this clinical data, and it has been published. And it was a randomized placebo-controlled 3-arm trial. What does this mean? It means that it used to have 4 arms, but one of the therapies was dropped. So the patients received for 90 days Doxofylline, and in a dose of 200 milligrams, 400 milligrams, or 250 milligrams, or placebo. The primary parameter to measure outcome was FEV1, so forced expiry volume after 1 second. So please take into account, I'm not going to repeat this. If you have questions about it, don't hesitate to ask Susan or ask in the chat. And the secondary parameters were rescue medication, asthma event rate, and safety. So this study specifically focused on these asthma patients. And what it found is that the efficacy of Doxofylline and theophylline were very similar and significant over placebo, and also crossed the minimally clinically relevant threshold, as you can see over here. However, as you can see on the right, you'll see that Doxofylline has a similar safety profile. However, the severity of symptoms was much less compared to theophylline, and the dropout ratio was also much less compared to theophylline. So the safety was significantly improved. You will see that the patients, there were still some patients with headache, but instead of a light headache, it was a severe headache with theophylline, and therefore you see that the outcome of the study results in a lower dropout ratio. On the left over here, you can again see this line, and what you will see is that the FEV1 increased by over 15% for both therapy options. So it's an effective bronchodilator to be used in lung symptoms. So it's been performed. It was a very big open label study in the US. So this study was a single arm open label trial where the patients received Doxofylline 3 times a day for over 1 year. The aim of this study was again to show what the clinical relevance was, but also what was the long-term effective treatment on a very high dose. So you saw here that secondary outcomes were rescue medication use, asthma event rate, and safety, being the primary parameter being FEV1 again. As you can see, 300 patients received a very high dose of Doxofylline. As you can see, the minimal clinically relevant threshold was passed again for the whole period, and the patients maintained with a good relief of their asthmatic symptoms. What is also interesting is that there are, of course, always safety concerns. You have that with every kind of treatment, but you see that the treatment was well tolerated and the dropout ratio was relatively low on the total amount of patients, especially considering that this was a 3 times a day treatment being used for over a year. So there were no serious toxic events found during this trial. So in the former 2 options, you saw that doxofylline was used as standalone treatment. However, in the current treatment landscape, as I presented in the beginning, there are many different treatments being used. This trial, which I'm going to present now, is the combinational therapies. So the patients received budesonide together with either formoterol, doxofylline, montelukast, or tiotropium. And again, they measured FEV1, the rescue medication used, the St. George Respiratory Questionnaire, and the asthma symptom score. This was a 90-day treatment, and it was an open-label parallel group clinical trial. And what's really relevant here is that this trial is a better reflection of the actual current treatment situation with a lot of severe asthma patients. And what you see over here on the left and on the right is that the treatments actually performed quite similarly compared to each other. So here on the left, you can see that formoterol was a slightly bit better compared with together with budesonide, but montelukast, tiotropium, and doxofylline were very close range of each other, being a non-significant difference between those 3 treatments, especially after 180 days. If you take a look at the St. George questionnaire, however, you see that doxofylline was preferred a little bit better over some of the other treatments. And also what was measured is that side effects for doxofylline in this study were slightly less compared to montelukast, but they showed equi-effectiveness. Therefore, what you can see is that as with montelukast, this treatment cannot only be served as a replacement of theophylline, but as standalone, together with other therapies, also has a positioning in the asthma treatment landscape. Another study performed together with even with 2 different treatments was the double dose inhaler and even a triple inhaler versus double inhaler with montelukast and double inhaler with doxofylline. And they took 50 adult patients, and in this trial performed in 2010, they saw that at the end of the trial, there was no significant difference between treatments with montelukast or doxofylline or with a triple inhaler. What does this mean? That doxofylline could also serve as a very valid treatment option before increasing the inhaler response. So it could also serve as a replacement for one inhaled corticosteroid. And therefore, I think you could call it a quote-unquote steroid-sparing effect, that it can serve as a replacement for upping the steroid dosing your very severe asthma patients. We also tried to find in one of our studies performed in 2018 by Riffo Vasquez from the King's College London, together with Professor Pate. What we saw is that when we had we tried to see the inflammation inside of the cells. We had again a OVA-induced inflammation model, and therefore what we saw is that when we added dexamethasone, for instance, we saw the inflammation go down. So we see less eosinophils here on the left, and if you see less eosinophils, it means the inflammation goes down. And what we saw is that the eosinophil count went down with dexamethasone, which you expect because it's a corticosteroid, which should bring down inflammation. But what we also saw is that in a dose-dependent manner, we saw that doxofylline also had decreased the inflammation, and therefore you required less steroids to a quite similar manner compared to dexamethasone. However, if you take a look at Montelukast, you see that this therapy, which we also tried to measure, did not see a reduction of inflammation. So we know that doxofylline has this reduction in inflammation, for instance. And also in the combination of doxofylline and dexamethasone, we see a very similar outcome with doxofylline 0.1 milligram plus dexamethasone 0.1 milligram versus 1 milligram of dexamethasone. These are very comparable. What you can see here is that it also has a synergistic effect to a certain extent. That doxofylline and dexamethasone together collaborate to a reduction of the inflammation count, while doxofylline with Montelukast did not have a similar effectiveness. It was quite similar to the 0.1 milligram of doxofylline only. So in this specific model, you could deduce that there was some kind of inflammation reduction observed with doxofylline. And I think that's a quite interesting finding again, and also relates to what was previously mentioned. This is why we call it that there is a steroid-sparing effect with doxofylline, because we think that by treating with doxofylline instead of another corticosteroid might help benefit your patients in the long run. So to summarize a little bit of the asthma treatment, what you will see is that it's as effective as theophylline, but with a much better safety profile. And also a very big advantage of this is because of the broad therapeutic window, there's no monitoring of plasma concentrations required. There's also a flexible dosing scheme, so you have 400 milligrams twice a day or 3 times a day, which can benefit your patients down the road, and will also give you the flexibility to provide another tablet if required at a certain stage. However, we saw with the 3 times a day, the amount of side effect was a little bit higher, but still in clinically relevant low margins compared to 2 times a day. It's effective as standalone or as combination treatment with inhalers, and you can consider a steroid-sparing effect of this treatment. And I think those are very big advantages of treating with doxofylline on its own. I would like to continue also with the clinical proof in COPD for a moment. So for COPD, doxofylline has been used for over 70 years already. It's now only considered a third-line bronchodilator after all the other treatment options I already mentioned before, but it's still considered a useful treatment. Only the main drawbacks of this treatment is that if you have a withdrawal of theophylline, it will lead to clinical worsening. And many older clinicians have still been convinced by the value in severe diseases of COPD. There were some new insights lately. It's already a study from 2006 that has some anti-inflammatory properties, some reverse steroid resistance. However, theophylline is currently considered with one big main drawback, and this is its safety. And definitely, in considering the drug-drug interactions that it has, one should reconsider whether you want to use theophylline in your patients. And that's also a reason why in Europe, for instance, inhalers are much more favored over theophylline nowadays. Again, in the GOLD guidelines, theophylline is mentioned, doxofylline is, as I mentioned in the beginning. However, the theophylline and its whole class is mentioned still as other possible treatment options being still valid. What's really the clinical evidence we found again in COPD was in a 3-week randomized open-label study with 154 patients, and they either received doxofylline 400 milligrams twice a day or 400 milligrams of theophylline sustained release tablets. And what we found is that there's an significant increase in FEV1 after 3 weeks of usage, which was in total 11% mean increase of FEV1 in these patients. This was a much shorter study with doxofylline and aminophylline in acute exacerbations. So you can also see that the value of this treatment, because it acts quite quickly, as I mentioned in the beginning, within 1.5 to 2 hours you have your peak plasma concentration. This treatment can be used as a reliever treatment as well in acute exacerbations, which resulted in a 40% mean increase in FEV1. This is, of course, because of the exacerbation. The patient is very ill at the time, and therefore you have a very big, steep increase of your FEV1 compared to the normal situation where you will have a slightly lower increase, as I showed in the previous slide. There are a lot of other smaller clinical trials performed with COPD and Doxofylline, but I tend to focus on the meta-analysis because I believe it's the highest level of scientific proof. This meta-analysis was performed by Professor Cazzola and Professor Page, and it shows all the different xanthine treatment options and their effectiveness in COPD patients. First of all, they found over 1,158 patients in various clinical trials, both open label as well as randomized clinical trials. And in over 50% of the clinical trials, Doxofylline was used as the reference treatment versus the other treatments we see over here. So it was generally used a lot in the scientific endeavor. And what they found as primary endpoints is that if you take the FEV1 in change of baseline, you see that Doxofylline has a quite similar FEV1 compared to the other treatments, compared to theophylline, compared to aminophyllin, and it was significantly better compared to bamifyllin. So it's a very effective treatment versus this treatment. There was not considered so much difference in effectiveness of Doxofylline versus theophylline. But if you take a look at the risk of adverse events, you saw a very significant increase of Doxofylline versus theophylline, and also versus aminophyllin over there. So therefore, Doxofylline was the preferred treatment options, considering the adverse events only. If you now take a look, they try to summarize this in a good graph and to also show you the relative position of the various xanthine treatment options with COPD. You saw that the SUCRA score for aminophyllin and theophylline was much lower compared to Doxofylline. And the SUCRA score is the safety, the risk of adverse events. And while bamifyllin and Doxofylline have a very similar SUCRA score, the efficacy of the SUCRA was much better with Doxofylline compared to bamifyllin. So therefore, you can say that Doxofylline is the xanthine therapy with the most effective safety versus adverse event ratio of all xanthine therapies available nowadays. So to summarize, for Doxofylline, it is as effective as theophylline with a much better safety profile. And a meta-analysis showed an excellent balance of safety efficacy versus other xanthines. And it's the most used xanthine therapy in COPD in a clinical setting in clinical research. Finalizing my presentation, I would like to talk a little bit more about safety, because why does Doxofylline have so much better safety profile compared to theophylline? Of course, first of all, it has to do with the adenosine receptor antagonism, which is present in the majority of side effects of xanthines, and it can lead to nausea, headache, central nervous system symptoms, cardiac stimulation, vasodilation, diuresis, and therefore the treatment of, for instance, theophylline is not considered so favorable nowadays, because you have to monitor closely the therapeutic levels inside of the patient. However, Doxofylline has an absence of adenosine receptor antagonism compared to theophylline, and therefore we believe, especially in the A1, which you can see over here, there was a much higher effectiveness antagonism of theophylline compared to Doxofylline. Furthermore, if you take a look at the PDE system, there was a much lower enzyme inhibition of Doxofylline for the PDE 3A and 3B category, for instance, compared to theophylline. And therefore, this lack of PDE3 inhibition may account for reduced tachycardia and arrhythmia for patients. But what you will see is that because of this lower effectiveness on the off-site targets for Doxofylline compared to theophylline, you will see that the patient will benefit better, and therefore it might be one of the reasons why the clinical safety is much better for Doxofylline compared to theophylline. Overall tolerability, this is also displayed in overall tolerability. So if you take a look at the total amount of dropouts, for instance, in this study performed in 1989, you see that the total amount is much lower of the patients observing side effects, but also the effect on the dropout ratio is much lower. So it halts in this smaller clinical trial performed. So this is also the reason why we have these results, which I mentioned in the previous meta-analysis. Also, the effect on sleep, what we saw in the SACO study in 1995, is that patients treated with doxofylline have fewer nighttime arousal compared to those with theophylline. And again, this was a 3 times a day dosage of doxofylline, so it was quite significant dosage as well. Related to safety, there were no negative cardiovascular side effects reported with doxofylline, and it effectively reduced incidence of premature beat compared to other treatment options. So here it was compared with aminophylline, another xanthine therapy as well. So if we compare theophylline to doxofylline, for instance, you have for theophylline, you have a narrow therapeutic window, where you have to measure plasma levels. You have a lot of side effects, as mentioned before, and there are drug-drug interactions. While with doxofylline, we know we have a wide therapeutic window, so 2 times or 3 times a day, no adenosine receptor antagonism, no PDE3 inhibition, and therefore also and we also know that there's no interaction with cimetidine or digitalis, and therefore it's a very effective treatment option with less drug-drug interactions, and therefore it's easier to use in the clinical setting. Again, as I mentioned before, this slide I can skip. So therefore, I would like to summarize the safety. There are less side effects to the, as mentioned, the receptor effect, and the meta-analysis proved low safety profile, low side effect profile compared to other xanthine treatment options. The last thing I would like to mention before I round off is that nowadays the inhalers are much in favor. However, slowly the scientific field is turning back to the point, because inhaler therapy are currently not being used only as a relief option, but very frequently in a patient's life. What they also see is that the inflammation which is found in the lung, for instance with COPD, which you see a lot, spills over into the systemic circulation through systemic effects. And therefore, one can argue that having an oral anti-inflammatory treatment option for your patient, which is safe and does not have many side effects, can also benefit your patient on a larger scale than only for their respiratory symptoms. So to have these COPD treatments, of course, you need to do the traditional treatment options, modifying a systemic effect of COPD. So stop smoking, take bronchodilators, have inhaled corticosteroids, and computational therapy. However, you see that a lot of other treatment options are also available, of one of them being xanthines. And therefore, I would like to say, and to finalize my presentation, doxofylline can be considered a very good treatment option for your COPD and asthma patients. So doxofylline is a xanthine treatment with triple action, bronchodilation, anti-bronchospasmodic and anti-inflammatory effects. It has proven clinical efficacy in asthma and COPD, proven effective as standalone treatment and as add-on treatment, and it has an excellent safety profile and few drug-drug interactions, and is especially better tolerated compared to theophylline. And with this, I would like to conclude my presentation and hand over the word again to Susan to answer some questions you might have. Thank you very much for listening in with us. You're muted, Susan.
Okay, thank you, Matthias, for the wonderful presentation. So now it's time for a Q&A session. So for the participants, if you have any question, you can either type in the Q&A chat or in the chat box, whichever will do as well. So there is no question now at the moment. Maybe I will take the first question, and then all the participants, you are encouraged to type the question you have right now. Okay. Okay. Oh, there is one question. How long should asthma patient take furoxan?
Yeah, that's an excellent question. So in general, what you see is that patients often have flare-ups of their symptoms. In these kind of trials, as for instance in the latter trial, it can be used for a very long time. So if a patient requires this relief, you can consider giving it for a very long time. However, I can understand that economical factors might have an impact for a patient as well, especially in with lack of insurance. I don't know the exact situation in Malaysia. What I also know is that in Georgia, for instance, one of the territories where we also sell this product, there is a huge impact on the financial burden for a patient. So if an asthma patient has an exacerbation or has a uplift of their general symptoms, a flare-up, for instance, in spring, they tend to use it for a shorter period of time, for instance, from 2 weeks to a month. And then they already see a lot of clinical improvement, and then they return to the normal baseline levels. It's a very flexible treatment. It can be used according to your wishes to your patients. However, if you want to have a long time sustainable treatment, I would say to use it at least for 2 weeks, but that's the minimum, up to a point of, I would say, between 3 months to 6 months, be very effective, but it can be used for longer if required. So I am very keen on this product because of its therapeutic window, it can be generally used and can be considered relatively safe to be used for your patients.
Thank you, Matthias. Thank you. So the answer is like, for example, if patients are on a long term of asthma and they can use it for at least 3 to 6 months, and it's safe to use to at least 3 to 6 months.
At least, yes.
Yes.
But I would say start with at least 2 weeks, because otherwise the clinical effectiveness, as you see in the clinical trials, they ramp up after a month, and then you see that the clinical effectiveness is sustained for a long period of time. And then 3 to 6 months, I would say, is a very valid time frame.
Okay, thank you. Any more questions? Matthias, how about for those like a post-COVID patient and they are suffering from asthma or COPD? So are they encouraged to use Doxofylline?
Yeah, so we are currently performing a clinical trial in Georgia. Thank you for asking. Excellent question. And results of this trial haven't been published yet. That's the reason why they're not included in my presentation. However, we saw a more significant increase in the patient's symptoms after COVID-19. So we had these patients, they were hospitalized with COVID, had significant lung scarring as shown by CT scan. Scan, I don't know whether it was CT. And then what they did is they measured FEV1, and then they got 2 weeks of pyroxam, and then they came back to the hospital when they were discharged. So what they tried to do is they tried to see whether the patients with Doxofylline recovered more rapidly compared to without Doxofylline. And what they saw is that although the FEV1 itself was not significant, FVC was significant. FVC versus FEV1, forced vital capacity versus FEV1 was improved, and the clinical response according to the patients was much better with Doxofylline compared to placebo. What you see over here is that after long COVID recovery, you can say that Doxofylline can help you in faster recovery of your daily activities after being hospitalized, giving you more air to breathe, and therefore bronchodilatory options have a positive effect. And also the anti-inflammatory effects. So whether it's long COVID use, we don't know. We haven't measured. But what we do know is that patients after COVID recovered faster from the hospital. I would be very keen on knowing whether, if anybody would be using this in Malaysia, whether they also experience the same effects with their asthma and COPD patients.
Okay. Any question from the participants? In Malaysia, maybe we are a bit shy, so give us some time to type the
this
question.
Is a good thing. This is a good thing. We Dutch are way too direct.
Okay, what about a patient, for example, if they are using Montelukast, and is it possible to add on Poroxan as another treatment, or they can, or if they are not satisfied with Montelukast treatment, can they replace with Doxofylline?
Well, about add-on, you always have to consider the effectiveness for the treatment versus the adverse events. And drug interactions are not known between those two treatments. However, I cannot exclude that they are not there. So what I'm saying is be careful. Monitor your patient closely, but that's something which you should always do if you add on a treatment to your treatment portfolio of patients. For replacement, we saw in a couple of trials an insignificance between the effectiveness of Montelukast versus Doxofylline. So if patients are unhappy with their treatment and would like to consider switching to Doxofylline, I think it's a very valid, there's a very valid reason to do so, especially because the trial mentioned a 2 times a day tablet dosage, while it could be 3 times a day with Doxofylline to enhance the effectiveness even better. So those are considerations to take into account. Of course, a pharmacist and a doctor will always have to do their own personal view and to see whether there are any specific situational differences for this patient to prescribe Doxofylline on top of Montelukast. So summarizing, be careful adding it on top because we do not know. It doesn't mean that we do not want them to prescribe or anything on top of it, but we don't know clinical outcomes. And secondly, as a replacement, yes, very valid replacement therapy, also clinically proven.
Okay. There is one question. Is Poroxan safe to use in elderly? And is there any drug-to-drug interaction in elderly patients?
I really have to take a very keen look on whether there are for elderly specific any drug-drug interactions which might be relevant. However, in general, with most of the, for instance, beta blockers or, for instance, aspirin or any kind of often used cardiovascular treatments with Doxofylline, there are no drug-drug interactions for these patients. However, I cannot say that there are no. I believe there are a couple, but I really have to take a deep dive for a moment into the patient data.
Okay. Another question. What is the recommended dosing during the 3 to 6 month treatment with Poroxan? Is it 400 mg BD or it can lower to 400 mg OD?
This is a very, very excellent question. So all the clinical effectiveness proven mostly was with 2 times a day tablets. The only comparison we had is 200 milligrams 2 times a day, which is effectively OD, but over extended period of time. The clinical effectiveness was significantly lower compared to twice a day. So I would recommend start out with twice a day. Because it also has been proven that it shows relatively low side effect profile. So I would recommend doing it twice a day instead of once a day, as I think that the clinical effectiveness might be less. But I leave it into the careful care of the doctor and the patient itself. If they consider that once a day treatment is sufficient for the relief of their, for instance, very mild asthmatic symptoms, I'm not claiming that you shouldn't be doing that. However, the clinical effectiveness proven in clinical trials always with 2 times a day or 3 times a day, 400 milligrams immediately released dosages.
Okay, so we will recommend BD or TID 400 mg for the optimum efficacy.
Yeah, okay. I would say BD to start out with, and if you lack efficacy, go to 3 times a day.
Okay, thank you so much. And another question, are there that means any dosing for children if, like, let's say children, they want to take?
In Malaysia, unfortunately, not yet. So I'm saying not yet, we're working on this. But we have dosages for children. It can be used for children up to 6 years of age from the top of my head. We have a syrup available, and we also have a lot of clinical proof that it's effective as well. Recently, we performed a beautiful clinical trial for a steroid-sparing effect in asthma in children in Mexico. Again, not yet published. We're doing that. We're performing that kind of research as well. Yes, it's clinically effective. Yes, there are dosages for children. No, unfortunately, not yet on the Malaysian market. To my sad face over here.
Yeah, we only have a tablet right now available in Malaysia market for adult use. Okay.
But
hopefully
we've launched recently, and we're always looking to pursue new options to increase our patient portfolio. So I hope that it will be there soon.
Yeah, we hope. Okay, next question. For existing Theophyllene user, can I convert to Puroxan or any transition dosing?
Oh, this is a very difficult question, which I am afraid I cannot answer to you directly because I know too little about Theophyllene and about the withdrawal effects. I really wish that I could say, yeah, you can just switch, but I don't know. What I can say, however, I worry mostly about the withdrawal effects of Theophyllene in this case. It might be that you have to build off the Theophyllene dose and then build up the Doxofylline dose. However, I cannot give a conclusive answer on this one. But I'm really keen on finding out. So let me take a look who answered. That was an anonymous attendee asking this question. Send an email to Susan if you would like to, or to your local representative. Reach out to them. I'm happy to research this for you and send this article over to you if you're interested. However, I'm not able to reach you right now because you're anonymous. So please proactively pursue Susan or any of your representatives so that I can then take a look into this matter more thoroughly. Happy to do that for you.
Okay. At the moment, these are the questions. Maybe we can still have another 3 to 5 minutes to wait for your any question if you have.
There's a raised hand. Let me take a look. Daeng and Alicia, please write down your question in the Q&A so that it will be easier for us to answer.
Yeah.
Thank you.
Okay, Matthias, what about like at what stage of COPD or asthma patient is suitable to put on Puroxan? Like for example, asthma, we have mild, we have severe, we have at which stage the patient is suitable to put on Puroxan?
So as to go back, China and bold guidelines, you see that COPD with the different stages, you see that Theophyllene is considered in any kind of stage. What we have seen in our territories is that it's been used, not in a specific case in general, it's been used for mild asthma as a first treatment. It can be used in severe COPD as their third or fourth treatment sometimes. So it really depends on the preference of the doctor and the patient itself. However, the first thing I can say is in any case you're using theophylline right now, you can definitely switch to doxofylline. Next to that, I would say that it's a very valid treatment option. Next to that as well, and I would say that it just requires some time to master and to get the hang of it, whether you like it or not, in what kind of situation. However, we see most clinical findings are in moderate to severe patients because there's, of course, the most clinical benefit to be gained. But I also know that, for instance, doxofylline is broadly used, especially in children, as a go-to treatment option over inhalers because a lot of patients prefer to have that. So it really matters on the patient, whether they like to have inhaler or oral therapy, whether they are severe or mild. It's really up to them.
Okay. Okay. There's two more questions here. The first one is, after 6-month treatment, can pyroxan be taken off instantly? And what about withdrawal symptoms?
There are no withdrawal symptoms experienced with doxofylline. No. So yes, you can take it off completely.
Okay. And the second question is, can a 16-year-old take pyroxan?
Well, as I mentioned before, the leaflet specified adults. However, we know that the dosage of doxofylline is also available in therapy in other territories where it's being used for 6-year-olds. A 16-year-old can take pyroxan. However, what you have to consider is that, of course, that the body mass is different, that the patient is younger, and also because the leaflet specifically mentions adults, it would be an off-label use in this case. But if you have a fully grown 16-year-old being the size of an adult, like we have seen clinical effectiveness in children from 16-year-old as well. However, I would like to state that the leaflet specifically mentions adults, and therefore that is my official recommendation in this case.
Okay. One more question. Can it be continued beyond 6-month duration?
Of course, yes. To go back, here's the Leicester trial, and here we have a 3 times a day, a year treatment even shown. So there are cases very well known of patients taking it chronically for longer. However, I'm always an advocate of treating minimally. So I would, as a doctor, always consider whether or not after 3 or 6 months it's still required to take the treatment. But you take it for, you can take it for as long as you want. However, a good doctor in the Netherlands will definitely take a look at your treatment options, therefore come back to you stating, do you really need this treatment still? For instance, you also have seasonal flare-ups with the hay season for COPD and asthma, and so it's all up to the hands of the practitioner using it.
Okay. Okay, one more last question. From the clinical study, Doroteo 1 and 2 shows that the patient of theophylline group changed fast from baseline in 2 hours post-dose FEE1. So is it suggest theophylline more efficacy than doxofylline?
Again, no, I would say not. But what you must consider is that doxofylline and theophylline are 2 different treatments. And because of what we already show at a molecular level, they are not the same, and they do not have the same, they do not act the same treatments. What we could say is, what you can also see over here, that the effectiveness of theophylline and doxofylline is already in line during the second visit, after 2 weeks. However, what I must say is that probably it already was in line a couple of hours later. So what I can say is that the theophylline effect might be a little bit faster, as we can say for sure based on these results, but we cannot say that the effectiveness is less. Also, what I would like to state is that this is in 2 trials performed. And in other trials versus theophylline, we see a very similar effectiveness. And what I always look at is, although theophylline might be a little bit faster in this case, if we're taking a look at the benefit-risk assessment of those 2 treatments, I would definitely say that for the long term, the patient benefits much more with doxofylline compared to theophylline. And that's the main message I want to take away. I cannot argue on the specific details if the Doroteo actually shows that it's more effective or not on a very short term. That I cannot help you.
Okay. Thank you, Matthias. I think is about there. Okay, so thank you very much for helping us to present about doxofylline to our healthcare professional in Malaysia. And thank you very much. So that's all for today. We will end the session now. So thank you all the doctors, pharmacists, ladies, gentlemen, for logging in our session today. So have a good day and thank you. See you again soon. Bye-bye.
Thank you very much for this opportunity. See you all in Malaysia sometime. Bye.
Eurodrug. We research for the human needs of tomorrow.